Hi, welcome to AIG Hospitals. Actually, today it will be yet another session of an interesting technology that is going to be showcased for the first time in the Asia Pacific region. Conventionally, whenever we do this advanced GI malignancies, diagnostic laparoscopy has become part and parcel of the entire procedure before we embark on how to proceed on this patient, either minimally invasive, robotic, or open surgical. So conventionally, whenever we're doing this biopsies on table, actually, suppose we do a routine diagnostic laparoscopy, we used to depend on pathologists for any frozen section biopsy for any nodules or nodes or omental nodules. Conventionally, this actually, depending on the hospital layout and the distance of the pathology department from the operation suites, these specimens are usually carried either manually or through the chute to the pathology department. And traditionally, it used to take almost about anywhere between 20 to 30 minutes, actually, basically, depending on the amount of distance this has to travel. So whenever we have a chute in the hospital, it becomes slightly easier, but you don't have a chute in the hospital, then obviously that whole thing gets delayed. And it's very, very difficult to have the pathology department inside the theater, basically because of the logistics issues, because we don't know how much time it takes for the surgeons to take the biopsy. So it is very, very illogical to have a pathology department within the operation suite. So conventionally, we all been depending on frozen section biopsies from the pathology department, and time has been the issues. And obviously, we also have issues like, suppose we take the biopsies and we get some negative biopsies, we have to wait for about 20 minutes, again take another biopsy, and again send it for again. So it obviously taking out a lot of human resources, the theater time. So there is a new technology that has come, actually the confocal microscopy, actually, that is actually giving us histopathology images almost absolutely similar to the conventional HND stains that we get. This is an absolute new technology that has been showcased in some parts of the world, but from the Asia Pacific region, this seems to be the first ever live transmission and first ever demonstration to showcase how this can be used. We have with us actually the person behind the scene, Dr. Babak is here, who is going to take you through how to process this and then show you the entire technology. Then we also have a senior pathologist, the director of pathology, Dr. Anuradha here, who will discuss in detail with Dr. Babak and see how useful it is and how it can be compared to the conventional frozen section biopsies that we have. So this seems to be, because we have tried this on the endoscopy side, it's very useful. So we are trying to see if the same thing can be applicable onto the surgical side. And to take you onto the surgical side, I have Dr. Shreyash, the senior consultant laparoscopic surgeon with interest in hepatobiliary surgery here. We have a patient induced here, a case of carcinoma stomach with gastric outlet obstruction who was planned for surgery. So over to Dr. Shreyash, he'll run through the operative procedures and then we'll see what best can be done in this patient.
Yeah, thank you, sir. So this is a case of middle-aged man with a carcinoma stomach having gastric outlet obstruction. So preoperative PET scan was done, which did not show any obvious peritoneal or liver metastasis. As our routine protocol, we do staging laparoscopy in all cases, and after doing staging laparoscopy, we found these multiple white nodules on the peritoneum. So this looks like metastasis. There is a puckering around and vascularity is increased, but the final diagnosis is pathological diagnosis. And for that, our routine protocol is to send a frozen section, like Jivro sir said, and that takes around 30 minutes duration. Also in the frozen section, sometimes if the tissue is not adequate, then we might have to do one more section. So with this technology, we'll be able to reduce the time significantly to a lower level. So I am going to take a biopsy. So the key point here is not to use any energy source, because that will distort the tissue architecture around the suspected lesion on peritoneum. So I am cutting with cold scissors. So in a laparoscopy, the pneumoperitoneum, after cutting the peritoneum, the gas goes into the extraperitoneal space, and it itself helps in a dissection. Come back a little bit. And we can take the whole nodule as it is. The larger the nodule, more probability of having a correct diagnosis. So my aim is to remove the nodule intact without damaging the tissue architecture. Non-tooth है इसमें नहीं है non-tooth. So this tissue will be handed over to Dr. Babak for the further processing of the specimen. It has been informed to me that they can handle specimen of size up to 2 to 3 centimeter. So this is around half a centimeter IQ specimen.
Thank you so
Okay,
much.
so the specimen has been handed over.
Babak here.
Thank you so much.
This is Dr. Babak here actually, who would be processing the thing and show you how to go about the thing. And we have the
Maryland
pathologist
Scotty,
also, Dr. Anuradha, who will tell you how different it is from the conventional frozen section biopsy.
Maryland with cautery.
Thank you very much. So first, I try to permeabilize the tissue, and then follow the protocol, a standard protocol, staining with the fluorescent dye, acridine orange and fast green. Acridine orange is penetrate to the cell nucleus, and therefore it's represent hematoxylin in the or H&E-like images. And later on, we do the staining with the fast green, and the fast green is actually representative of eosin in our H&E-like images. So basically, we can visualize extracellular matrix, collagen with that. So first incubation is 30 seconds, and the second incubation is 20 seconds.
So, Dr. Babak, what do you think about this? Is there a lot of fat around here?
Yes, there is a lot of fat here. This is omentum. We did it actually before and also here. So one of the advantage of this technology is that the fat structure is visualized very good with this, our technology, because we are not damaging, harming the samples. The sample is still hydrated, so it's not like FFPE or frozen section. And then the fat structure is very well preserved. So
yeah. So as he is staining it, normally when we get frozen sections, for the pathologist, whenever there is a lot of fatty tissue, the greatest difficulty is in cutting the fat sections. So that is why there's a little bit delay whenever the tissues have lot of fat, like an omental fat or anything which has a lot of fatty tissue around it. So let's see how this technique is going to be different. And also cutting the sections take a little longer time, because when we take a lot of sections, the sections float off. So the area of interest to retain in the slide sometimes becomes a challenge in the routine processing.
very good. You have another.
So they are doing like a rapid H&D stain here. So, but he's using acridine orange and fast green basically to stain the nuclei and the background stromal tissue. So he is finished staining the cells, and he's loading it onto a glass slide which has magnets in it, and he's washing it with saline. And now he's in the last phase of mounting the slide onto the So I think it took just a minute and a half before the sections were ready to be mounted on the machine, which is quite fast when compared to what we can do in the routine way. And this is the tissue which is stained.
Maryland with cautery.
And now he's scanning the machine, the tissue in the machine, right?
Yes. So now the objective will localize underneath the tissue sample.
So in less than 2 minutes, the tissue is ready, and as you can see, he's scanning the tissue. And you can already start seeing the fat vacuoles, and you can see some of the nuclei of the fat spaces as he's mapping the tissue.
I go to different region to adjust the laser intensity. And now I'm selecting the full region and starting the scanning. So we call the technology also ribbon scanning microscopy because it's ribbon which are stitched to each other one by one, covering the interest area.
So you can see that the machine is scanning the entire tissue, and you can see on the right side the mapping of the zone, and on the left side you can see the beautiful microscopic image, just like we get in a frozen. And this is very impressive that all the fat lobules are intact. And Dr. G. Rao sir will give you.
This is really amazing to see this fat globules like this actually, and then
Because from the pathology point of view, whenever we have fat, sir, it is difficult for us because it floats away. So we need a very expert technician and an expert technician to cut the frozen sections. So there's a lot of delay whenever we have fatty specimens. The orientation of the specimen also becomes difficult, but as you're seeing here, it has mapped the entire thing, and you're getting the total picture. And if you see this bluish areas, these are the cells. And now we will go to the microscopy.
So it's actually stitched, and now we can open the image and zoom.
Yeah,
So which area?
I'll just show this.
Okay.
So if you see these, these are the fat vacuoles. So this is all, and here you have some cells. So normally in the fat tissue you will not have any cells. So this was a case of suspected malignancy. So you can see the cells here, and then I'll show you the other areas.
So one of the advantage here is that this digital image you can navigate through and go live again back to the sample because it's still sample loaded on the microscope.
So sir, this was a case of
and another just out of curiosity I'm asking actually, this is the peritoneal biopsy. So normally we don't see any cells. So the pathology, even without the pathologist, we can tell that some non-peritoneal stuff is there in this in this, and then it could likely that could be something malignant.
Also, it could be inflammatory, sir, but you are even at the surgical site, even without a pathologist on site, by seeing the cells, you know that there's some etiology, some neoplastic etiology. It can be benign or it can be malignant, but you are able to make out it's not normal.
Yes.
So this saves a lot of time for you to go ahead.
Yeah, almost it saves us the negative biopsies. Now, I mean, like this biopsy is as good as good. Actually, we don't have to take one more biopsy to confirm it with histopathology.
And this is the case of suspected malignancy. So you can see that there are some clusters of cells here. So then you can say that whether they are lymphocytes, sometimes you can get inflammation also. But here you can see that there are small nucleoli here. So this obviously looks like atypical cells. So I'll just zoom in some more areas. Yeah.
Yes. Sometimes we call this
you can
2D
even
because
see
it's a little bit 3D.
These cells here. So this is a adipocyte, and this is adipocyte nuclei, which you can definitely make out what is a benign cell here. And you have some inflammation also in the background. So we can just go to the areas wherever there is more cellularity. And here you can see that there is overlapping of the cells, and there's some acinar arrangement. So what was the exact history of this?
Carcinoma stomach.
So you can see that as the history is also there, and you have large cells here. We'll just zoom in. So this probably we're dealing with the metastatic deposits here.
The other biggest advantage Dr. Babak tells me was that actually we can even take sections on the same thing at different, unlike the, without really sectioning, we take the laser sectioning of this tissue. Can you just show us that
Yes.
technique, Dr. Babak?
For example, in this
You take laser sections of this
Exactly.
without really sectioning the specimen.
Exactly. These are optical sections. So if you click here in the this reticle, then you go live to the same region, and we can go a little bit upper and then start the stack.
So now he's sectioning within the selected area right now. This is sectioning without really sectioning the specimen. It's called the optical laser sectioning actually. So we get different layers at the same site here.
So normally, whenever we get a frozen, we try to see the serial sections to identify the cells and to know whether we can see the arrangement of the cells or what. So here, without cutting the tissue, he's actually able to go to deeper levels and also orient the cells in relation to the background cells. And also, probably whenever we have a doubt in the frozen, sometimes because of the fat thing, here we are able to see the entire section like a macroscopic view. As we are seeing the macroscopic tissue, this microscope is able to show an overview of the entire thing.
Exactly, and you can navigate through it, and if it is necessary, go live and go to different
So
layers.
like how he is going in and out, so he's able to, if you see in this section, these cells are now coming up from the deeper area. So these are the inflammatory cells and lymphocytes, and then you are able to see these cells here. So this is one advantage. And then again, if you go back to the original slide, so you can see that this is all lobules of benign adipose tissue. So sometimes in the routine frozen, the sections can get cut off. So it becomes difficult for us to orient and identify these cells, particularly if it's a signet ring cell morphology. It sometimes becomes difficult for us to identify between these fat lobules and those cells. So here, what I'm able to appreciate is the nuclear details are very well maintained. So it is able to give us a very good, so I think this is a very good alternative to frozen in the OT, which as a pathologist I should agree.
So it saves us a lot of time actually, the operating time actually. Otherwise, we literally actually we take the biopsies, wait for about half an hour actually, and then wait. Shresh, what do you think, Shresh? Now actually, it's saving your time. Actually, what is your opinion about this?
Yeah, definitely. In the fast-moving world, time is money, that they say. So any time that is saved is beneficial for the patient to make a quick diagnosis as well as to reduce the anesthesia time. I would like to ask Dr. Anuradha madam. So here, after seeing this images, you say it is a probable metastatic deposit of adenocarcinoma. So if you see it on frozen, like if we send this specimen after this study for frozen, will there be more confidence in your opinion, or it will be almost similar?
So it's just like a transition from the routine morphology where the doctors used to traditionally see into the microscope, and today we are moving to digital microscopy. So I think it's just that learning curve for us from moving on to see the slides actually under the microscopy to digital microscopy.
So we should have a large sample size to believe that what this shows is actually what we see on histopathology.
I don't think you need a large volume. It's just
Maybe.
a small learning curve of few cases,
Few
because
cases.
it is like the routine digital microscopy.
yes.
Instead of looking into the microscope and then changing the field
Okay.
manually, here we are able to see the entire thing at a glance and go to the area of interest. And
Okay.
also 2 or 3 pathologists can you know
Yes.
actually see at the same time, so you get an opinion at the same time and of the entire area, and
Yes, sir.
chances of missing are also less because everything is there in the
Yeah.
screen.
And since these
Yeah,
are
actually, the other thing is actually the technology is such that this can be connected to the pathologist anywhere outside the operating room. Right now, Dr. Anuradha is spending some time here in the theater, but actually these images can be transmitted live to her department, her wherever it is, and then it's able to that they can manipulate the entire thing and then give us a diagnosis here. Now, you think you'll be able to tell us the site of origin by any chance? Actually, this is by any chance, actually, Anuradha, you think, or you? But we know that the next generation is going to come where they're going to have the IHC stains and all that. Do you think IHC stains are required, or do you think this is sufficient to make a?
If it is a well differentiated adenocarcinoma and we see glands, then I don't think I would usually ask for IHC. But the question is when it's a poorly differentiated tumor, and also this is from the peritoneum, right? So in peritoneum, normally we also want to rule out mesothelial cells in the lining. But obviously this is not in the lining. So in such cases, we would ask for IHC only when the percentage of tumor is less. But if the percentage of tumor is more, then I think we normally are able to go with it.
Yes.
Anything else, Shresh, that you think that you want to add to this, or Dr. Babak, anything else that you want to add to this, whatever we've been shown to us? I know that you said actually the IHC is going to come very soon into this actually,
Yes.
so that we can wherever, like Dr. Anuradha said, whenever we have a poorly differentiated adenocarcinoma, we can always type the thing. Actually, suppose unknown primaries, and then we can do a diagnostic lab, then you want to type the thing. I think it makes a lot of. So, how much time do you think the IHC will take in future? Suppose
So
if it comes.
it is under development. So we talk already with a couple of specialists in computer field. We are developing our neuronal networks based on our a pool of images, and it will come in future. Of course, it needs more samples and effort to develop it.
Shresh, you think it's changing your line of management now, Shresh? Actually, now you plan for a D2 gastrectomy for this patient?
Yeah, for this patient, as it is a metastatic disease, we will be going for palliative bypass.
Right. So, I mean, the entire thing actually, it's a very good technology that it's within a short period of time, we're saving time, and they were able to change within 5 minutes, we are able to conventionally, actually, our pathologists take 7 days actually. Though we put it as 5 minutes, actually, our pathologists take 7 days to get the biopsy specimens. So, basically, from 5 days, we're getting down to 5 minutes right now.
One more thing I wanted to discuss, Dr. Anuradha. When we send a frozen section and you say probably it is a poorly differentiated malignancy, you don't know the site of origin, and you order IHC, will you be able to tell which IHC markers to do immediately after this, or you need histopathology final?
So normally, when we do regular frozen, they are frozen artifacts.
Okay.
So what I see here is frozen artifacts are minimized. But for any patient, for any IHC, we need to know the background history. Otherwise, based on the patient sex, that is male or female, and the thing, we go in a panel.
Okay.
So we recommend a standard panel of markers to identify the unknown primary.
Because normally what happens when we send a histopathology, after the report comes, there will be advice of IHC markers,
Yes.
because some further diagnosis is required. So with this technology, will we be able to order the IHC markers right onto table, like before coming, before the histopathology report is
same
out?
like the
Histopathology.
regular frozen, but the advantage is you are able to normally whenever we have fatty tissue, we don't get such a good thing. I should agree on that, because fat is one major thing where even the most experienced technician is not able to give us a good section, because fat floats off, and you need a very skillful technician who is going to cut those sections. So sometimes when all this is detached, we get only islands of cells. So that means at the time of frozen, at least I'm able to tell you it is positive or negative if my sections are bad. And then I rely on the regular sections to see more nuclear and cytological details. So here, if you see, everything is maintained. You're able to see where the cells are and all. So we can say what is the malignancy, and of course we can go ahead.
So, Dr. Anuradha, you're telling us that on frozen section biopsies, you don't see these fat globules, so it becomes very difficult. Now you're seeing a sheer contrast between the fat globules and the cells, dysplastic cells.
Depends on the experienced cytotechnologists. So most of the time, like it is difficult. Even an experienced technician sometimes fails to give us a better section because of the difficulty in cut.
So we take it for granted that between an unexperienced technician and this is superior to the thing actually.
This is definitely superior, and I was also counting the time. I was able to give a diagnosis in 4 minutes. So this is fantastic saving of time. And even if we would have asked for a repeat, it would have been a matter of just another 2 minutes. So it definitely will.
The other biggest advantage, as Dr. Babak tells us, actually, because this is not going to change the conventional histopathology now. So the same specimen can be put it in formalin now. Can we have a formalin? So the same specimen now, we take it out actually, and we'll just tell you how to, I mean, we're not doing anything else. We're just taking this out, and then it does not hamper with the histopathology or the IHC staining that we have to do in future. So the same specimen goes into the formalin to compare ourselves actually. So we are running a trial actually between this and the conventional histopathology to see how different and how efficient it is. So he's put it in this now, and we're going to put this in the formalin. Formalin. Yeah. And then we'll transport it to the pathology department.
So the samples are fully preserved. You can do a standard FFPE or frozen section and follow the
it does not hamper with the further
no. And also molecular analysis, so you can do PCR or next generation sequencing.
Thank you so much. So that is a beautiful demonstration. Thank you, Shresh. Actually, we'll proceed with the routine gastrojejunostomy in this patient. So we'll just switch on to the other theatre actually, where we have Dr. Siddhant, who is washed up for a right colon growth again. Basically, patient came with obstruction, so we had to take this patient for surgery. So we just put in a scope, we'll just see what the findings are, and we'll see if anything else can be done in the other theater. We'll just come back to you, we'll just go back to the other theater and see what the findings are.
Good afternoon all. Good afternoon all. This is Dr. Siddhant. Actually, this is a case of a young male, 35-year-old male, who presented with us with history of pain in abdomen since 10 days. He was investigated outside by doing a CT scan which showed a mass at the terminal ileum IC junction area. So we did a colonoscopy, and colonoscopy showed multiple ulcers in the terminal ileum and extensive compression at the cecal area. The biopsy from which showed adenocarcinoma as well as foci of the neuroendocrine tumor. So we did a PET scan with FDG and DOTA PET also combined, which showed lightening of in both the areas, terminal ileum as well as one small metastatic lesion was also seen in the segment 2 of the liver. Head up. Segment 2 of the liver, 2 centimeter size metastatic lesion is there. We did diagnostic laparoscopy. It showed a small, multiple small peritoneal nodules also there. And on palpation, it is little bit hard in consistency, but so we can see this area,
So in oncology practice, it becomes mandatory that whatever type, either going for laparoscopy or open, actually a diagnostic laparoscopy is pertinent in current day clinical practice. Basically, it changes the line of management in this. So in addition to this segment 2 nodule that you're seeing, Siddhant,
yes,
you're able to pick up some peritoneal nodules also.
Yes, sir. This is the lesion. It is little bit subhepatic.
So it is not on the seen on the surface of the thing. Obviously, Siddhant will go resect that subsequently. But here we'll take a peritoneal biopsy just to confirm this actually. Yeah. Can we see this,
Yes, sir.
Siddhant, actually? So we'll not use any energy source. We'll just use the scissors.
Head low.
Head up, please. Actually, can we?
Head low.
So the procedure is the same. What we did in the other patient. Actually, we are going to take cold scissors. Actually, we are not going to use any energy source. And then pick up this peritoneal nodule and subject it to histopathology. This is more for documentation of the thing that actually we are going to proceed with this case either way, but here we are to document that this is the peritoneal metastatic disease, that we are going to take biopsies from here, and obviously we'll take care of the liver met actually that is there on table. Actually we'll so the processing will be similar to what we done earlier. Actually we take just that, yeah. So we are not using energy source. Basically, we make sure that the specimen is not distorted. Thank you, Siddhant. Actually, we'll come back to you with the histopathology, but
Sure.
I think you can proceed with the procedure that you planned
Yeah.
for. Patient has come with obstruction, so we are going to do
Yes.
going to proceed with surgery. It's not going to change, but this is mostly to document
Yes.
the peritoneal pathology right now.
Cautery attachment. Cautery attach.
Siddhant, you proceed. We'll just
Yes,
give you the
sir.
thing actually. So
Sure,
we'll just
sir.
put it onto the thing and show you.
Thank you, sir.
actually, and Dr. Babak tells me that actually he can go up to almost 3 centimeter specimen can be mounted on this. Actually, you can see this. The entire thing specimen that he has taken out, is mounting it without taking anything. Actually, pathologists would have again selected which nodule to be taken and then put the whole thing actually. Is that right, Anuradha, or is it something different that you do in pathology?
We can process, we have different sized blocks in the pathology department, sir, from small to big. So our maximum size, we can go up to 2.5 centimeters, but beyond that we cannot go, because we need to cut it, or we'll cut it into 2 and make it into 2 bits for better appreciation of the morphology.
And now I'm staining again with acrylic orange to visualize the cell nucleus, and following that with fast green to visualize extracellular matrix, mainly collagen fibers and elastin.
And during routine frozen, we have some challenges, like if our frozen machine, the temperature has to be maintained. So, because of various factors, the temperature is not maintained. So at that time, it is difficult for our technician to cut it, because we instantly freeze it. So if that instant freezing needs to have certain temperature regulation. So what I see here is there is no external factors affecting this process, which is also a major advantage as we see. So there is nothing which is temperature related or AC related or machine related. And sometimes when our machine suddenly conks off, we are not able to do any frozen.
So you never told us about all these limitations before, Dr. Anuradha. Actually, I thought frozen section biopsy were a simple, straightforward thing at all. I never thought it depends on the air conditioning of your room and all, actually. Surprising, actually. So a lot of negative biopsy that you're getting, we could be positive because of the air conditioning system also. Is that right, actually? Okay, fine. This is basically the biggest advantage of this thing. Actually, Dr. Babak tells me, suppose if you take a node out, actually, you can put the entire node and you can do an optical sectioning without sectioning the node. And he can tell us actually right from the surface of the lymph node to the core of the node to the other side of the node. He can really section the entire thing actually. So here we see the same thing actually. Now he's taken the entire specimen, he's going to mount it here.
I'm doing the final wash.
So compared to this actually, you think your frozen looks prehistoric now, Anuradha?
I think slightly, sir, because whenever we get a large node, we do resect it, because we want to see where, as you rightly said, whether there are any nodular areas or gray white areas, and we want to make sure that we are going to incorporate that bit particularly in the frozen section. But here, since the entire tissue is getting scanned, I think that aspect of it, and also sometimes if any juniors take up frozen, there are chances that they can miss that area. And then again, we have to go back and all embed the specimen. So it adds to the time factor. So this definitely is advantageous.
So now you can see that actually the specimen, the entire specimen, whatever has been taken out has been mounted. We're going to scan this.
So,
and the images are such high resolution images. Actually, just imagine that this machine has got a storage of 20 terabytes. So imagine the amount of the quality of images that we get in this are something phenomenal and really high quality images. And the space required to store these images seems to be very high. And Dr. Babak tells me there's almost about 20 terabyte storage that have in this machine. Dr. Babak, can you just tell us the same thing again? So it's
yes, so we need to have a special computer to handle all of this data, and of course we need also a lot of space, because each image is actually very big. So I'm trying to now go to very surface of the sample and look at different places.
Again, basically, even without the pathologist in the theater, we can say, because this is a peritoneal biopsy, normally we see these fat globules and some amount of fibrous tissue that you're seeing actually. And there's some cells actually stained actually. As you rightly said, it could be benign, it could be malignant actually.
Let's start.
So I think we'll get replaced soon.
This is a very large sample, but
The biggest advantage, this is the very last, I mean, comparatively, this is not like the endoscopic biopsy, this is a bigger biopsy, and the entire thing has been put on the slide actually without damaging. And you can see this is literally scanning the entire tissue from one end to the other end right now.
And of course, later on we can zoom and see
Yeah, so
more
later on you
detail.
can zoom and then you can see the fat globules actually, as what Dr. Anuradha was talking about before. Yeah, those are the fat globules. We have already learned, Dr. Anuradha, actually we learned the histopathology now. So we learned the pathology also within 5 minutes now. Thank you, Dr. Babak, actually. We learned the pathology also within 5 minutes now.
So this is a new technology. Of course, we are happy to provide it to different countries in European countries, as also here coming to India. We are very excited here. And this region, I can say that we can do one section and go down. So this area is actually in the another Z, in the depths. We can image them.
So you can
another
optically
layer.
section that area to see
Exact,
different levels so that we can.
This during the frozen sections where the tissue gets floated off. So there again we'll have to take multiple serial sections. So let us see how Dr. Babak takes serial images through scanning.
How much time does it take to train people for this, Dr. Babak, actually?
So usually we are doing the training. It's depending on the application, but usually it takes 1 or 2 days for the training.
For the trainer to.
And every normal technician can handle the device.
And I was told actually because this has already been extensively used in prostatic surgery for to make sure that we get negative margins on table. So we also, it's possible that whenever you're doing gastrectomies or colectomies, we can take the resection margin wherever we transected to see whether we're getting an R0 resection. Is that right?
Yes, so there is a lot of applications that popping up, and of course this is also interesting to look through. And actually most of these applications are new, novel, and maybe you also find some new areas of applications that one can look at the tumor margin.
So looks like, Anuradha, by the time the specimen comes out of the theater, we'll be able to give a TNM classification.
So that's the most major advantage which we can see, sir, as you rightly said, and there are many instances where particularly in pancreas, I think this will be very helpful in IPMNs of the pancreas where you need to go for multiple margins of the clear duct. So I think it's going to be very interesting in IPMN of the pancreas.
I think Shreyesh has got quite an extensive this experience with IPMNs actually. He keeps sending Anuradha umpteen number of specimens actually. That's the reason why Dr. Anuradha is talking about these things actually. Yeah, it's a very good application what you said actually, because we keep revising the pancreas margins
exactly
for this thing. Actually, it's a very good application. So you can see that it is beautifully scanning the entire thing actually.
You can see that this is the fat tissue here, and this is a fibrocollagenous tissue, and they are nests and pockets of bluish areas. So obviously, I think once the scanning is done, we can directly zoom on to these areas. So, and since it's a case of colonic carcinoma and peritoneum surgically, there was a strong suspicion of metastasis. Our first differential diagnosis, even before seeing this, would be to look either for a metastatic deposit or sometimes a granulomatous reaction secondary to cancer. But even at the scanner view, I don't see any granulomas, but there are some sheets of cells. Now I think the slide is ready.
So now it's finishing up.
The area of interest, Anuradha, actually we just saying, is this or this is the area of interest? Both also.
Pockets of areas are there, sir. So
I zoom here.
yeah. So you can see this a beautiful thing, and you can even see the nuclear details are very clear here. So you have nice acinar formation of cells. So I'll just go a little more, and you can see the ATP of the cells, and we can check some more areas even before we comment. So this is the fat tissue, and you can see even the inflammation, beautifully the neutrophils, even the inflammatory details. You can see the lobes of the neutrophils as well. And these are, again, this is one cell which looks little atypical. And look at this cluster. This is definitely atypical cell cluster. Look at the nucleoli, the acinar arrangement. So this is classic metastatic deposit. And in addition to that, even the background plasma cells and neutrophils are also very, very crisp and clear. So there is infiltration in between the fat spaces, and this is all Let's go to some other area as well. So here again you have 2 cells. Before Dr. Babak shows us how to map these areas, I would just like to see this one more area which looked blue. And you can see there is a cluster of tumor cells here. This is very, very clear. So I think even the surgeons can say now that this is positive. There you can see the nucleoli also. The details are, this is the nucleoli. The nuclear details are amazing. So this is like a metastatic deposits of carcinoma, and with this gland pattern, I would say adenocarcinoma. I heard in the starting of the history that we had given a differential diagnosis of probable neuroendocrine areas, but here this looks more like an adenocarcinomatous areas here. And can you please show us the stacking which you were saying in these certain areas where you wanted to, like these areas you said you
So
will,
for example,
yeah.
here, I go zoom, for example, in this region, and let's see. So you can go live, and you can do it but 2 different ways. First of all, with the scrolling the mouse. So I'm going
Just stop here. So what Dr. Babak is showing here is there was a artifactual space here. So normally we would need to take serial sections, but he is going into taking sections through the image, and you can see that there are cells here. So they are coming up.
So just the scroll of the thing is making.
with the mouse.
So yes.
Yeah. So of course this is live, and we can also do this with the serial sections with the Z stack. So I think
And you
this
can
is
see the increased cellularity.
exactly.
And here if you can see even that fibrocollagenous tissue there.
So I do quickly cover the depths. So
So-
now it's done. I just play this.
So normally in histology we take 3 to 5 micron section thickness. I think what is the maximum depth of the thickness here which you are going
So
up to?
it's depending on transparency of the tissue. So usually it's 60, 70 micrometers now. But basically, if the tissue is transparent like eye, the microscope can achieve 200, 150 micrometers. Yes.
That's even much more lesser.
The bottleneck here is the transparency. So the signal, because it's epifluorescence, the excitations, wavelengths should excite the fluorescence dye, and emission should come back to the detector. And if you have less transparency, you have more diffraction, and therefore the signal will be lost after 60, 70 micrometer depths.
So I think this is very important for margins, particularly when we get even the transhiatal esophageectomy specimens, and also there also whenever we get a frozen section and the distance from the tumor to the resection margin is less, I think
In fact, even for rectum now, actually, whenever we do this anterior resections, actually, we send both the donuts actually for histopathology, but looks like the entire donut can be put, and then we can examine the entire donut and then serially check the thing actually.
clusters and nests of cells here. So without any doubt, we can definitely sign it out as a positive for metastatic deposits here. I think that's fantastic.
Thank you so much, Dr.
You're welcome.
Babak. Actually,
You're
it's been an interesting session. Actually, it is completely revolutionizing what we are doing in the theater, saving time, saving operating time, saving anesthesia time, the theater time for the hospital actually, and also we're getting pathologists actually. So I think looks like actually, I mean, it's as in today, we're not saying that it's going to replace the pathology, but it is help us targeting the biopsies, decrease the number of negative biopsies that we get,
Exactly.
and maybe we can revise the margins on table so that it saves a lot of time in the operating room. It helps them in the anesthesia time, and obviously the morbidity would be quite less in this on this patient.
Yes.
So thank you so much, Dr.
Thank you
Babak.
too.
We look forward to see you with more of these
Of
ISC
course,
markers and all
definitely.
actually with this, and we
Definitely.
continue to use this in our department and showcase this technology in the interest of the patient. Thank
Our
you so
pleasure.
much. Thank you, Shreyesh, for this beautiful demonstration.